presentation, he had an impacted wooden foreign body between the left eyebrow and the lower eyelid with a periorbital edema, but none of the ocular structures were visible. We ordered for a CT scan of brain, orbit and paranasal sinuses, which clearly delineated a hypodense elongated structure extending to opposite maxilla and not corresponding to any possible anatomical entity suggestive of foreign body.
Exploration and repair is being done under general anesthesia. In order to expose the entry point of the foreign body completely, the soft tissues around it are being dissected meticulously to avoid any damage to the vital structures. After complete separation of the soft tissues adherent to the foreign body, a bone nibbler is being used to gently extract the intraorbital wooden foreign body. As the foreign body was hard and lodged deep into the orbit, a slow, wriggling motion was needed to successfully remove the wooden piece in tow. The wound was irrigated and sutured at the end.
At 3 months, he had a normal fundus and no ptosis or diplopia in any direction of gaze as shown in the video. It was quite miraculous to have a foreign body of more than 11.5 centimeter without damaging vital structures in and around orbit and to remove it safely without damaging any. To best of our knowledge, this is the largest reported intraorbital wooden foreign body till date.
Thank you.
It was really very nice presentation. How did you ensure that all the foreign body in toto has been removed?
We did a MRI before 1 day before surgery, and the surgery was actually done in a multi-specialty hospital in presence of neuro and ENT surgeons.
This was under GA?
Yes, under GA, sir.
And any antifungals?
Sir?
Any antifungals, because wooden foreign bodies are known to...
Yes, it has covered both antifungals and antibiotic for a week.
Thank you. Any more questions? Sir.
Thank you.
Thank you, Dr. Mohapatra. So next we call, is Dr. Behra ready? Yeah, so Dr. Sharmishta Behra from Orissa, currently Scientific Committee Chairman of Orissa Ophthalmological Society. So, is the audio working on this computer? Excuse me, Avi, is the audio working here? Can you please check? So, Dr. Taranum Fatima can get ready on this side if this is working.
Should I start, sir?
Yes, please. The timer is set to 2 minutes. Please start the timer.
Mine is a modified Fox Pentagon technique, which I learned from the YouTube videos by Dr. Susan Jacob. What we have seen is, in addition to the congenital ptosis, we have also seen very good results in adult ptosis as well. People who presented late. So this single stab has an additional effect that the inflammation is very less post-op. Besides this silicone string, when one can also use a true con, that's even more useful.
बदरिया घेरी आई नंदी, बदरिया घेरी आई नंदी.
Thank you so much.
Thank you. Over to the judges, please.
What was your post-operatively? There was no problem. Patient was happy?
Post-operatively, sir, for a single day, even we do not even give a patch after surgery, so that the person can have the mobility retained. And for a single day or for day 2, we have a little swelling, and then it's okay.
After ptosis correction, what defect was still there?
In some people, we have seen that this sling doesn't suit, so it causes a small granuloma over there. In few people, we had to remove it out and replace it with a proline thread.
Anyway, you did a very good job.
It is really very
You
nice
use this
procedure.
straight needle, right?
Yes, sir. It comes.
It comes as a straight
yes,
needle.
Yes.
So how did you make sure that you actually get that pentagonal kind of a track?
We mark it, sir, with using
No,
a
but
mark.
when you're marking it, but it may not actually, because straight needle is very hard to negotiate, it's a very long track.
It has a sharp cutting edge, sir. So that goes. It's not that difficult.
It'll go straight, it will not follow the pentagonal shape. So how do you ensure that you get
वो
that?
जाता है, sir. It goes.
Suppose you have not been able to track, negotiate the Fox pentagon, and your needle has been extracted somewhere else.
So that
because
will-
it is malleable.
Yes, sir. That will
then
cause.
in that scenario, what would you do? Would you do the re-surgery on the same day, because you can have profuse bleeding, or will defer the surgery for a week or two? What is your take?
Sir, actually, it's very easy. We do it under local anesthesia, sir. It's very easy. It just needs a little bit of practice. It has never so happened that we had to defer surgery.
No, since you have negotiated the
Yes, sir.
pentagon like this, so
Yes, sir.
many a times you want to externalize the point and to some point, and it rises somewhere else.
No, we have
Then-
to regulate it, sir. With a tooth forceps, it's easily we can achieve that, sir.
Okay.
So any post-operative exposure?
We have not seen overcorrection, but sometimes undercorrection happens, or even in cases when the child grows up, a little bit of correction may be needed, sir. Secondary correction.
Thank you.
Is there a deformity in the middle of the lid, a notching kind of a thing happening in some of the
It's
cases?
hardly there, sir. The pentagon is, the modified Fox pentagon technique is especially done for that. It's hardly there.
Good. So I think it's a very well done surgery.
Thank you, Dr.
Thank you,
Bera.
sir.
Thank you very much. So next presenter is Dr. Fatima. So she will be presenting on slow motion dynamic videography, a tool for the diagnosis and evaluation of strabismus.
Some motions are so fast that they are difficult to analyze. Time is in fact an arbitrary human-made concept. While a second always takes place the same amount of time, the human internal clock is a metronome working at high variable velocities. A blink is 100 milliseconds. Pupil constricts in 200 milliseconds. The cover test, one of the most important tests for strabismus, appears simple but is actually complex. Eye shift in cover test takes place in 400 milliseconds. Slow motion to study fast-moving objects was first invented by Dr. August and has been used in sports since long. In medicine, it was introduced in 2013. We used this technique for the cover test. We took video during cover test on Android phone.
The video was transferred to UCAT downloaded from Play Store.
The video was copied twice and speed of 0.5x and 0.3x applied to the second and third video. This video was then played and replayed on the media player. Here we can see the exoporia becomes more apparent in slow motion. We decided to do a pilot study. A group of trainees were shown the cover test. After that, video recording of the cover test was made.
And the recording was then showed to them in slow motion. They performed better with the slow motion technique. We published this data 2 months back.
Slow motion dynamic videography of the cover test can be helpful in the detection and analysis of strabismus. It can also be used as a teaching tool for future generations.
Thank you. Over to the judges, please. No questions?
What is the message which you want to give to the House?
The message I want to give to the House is that using this new technique, we can actually record this eye movement, especially when we are evaluating the squints. And because it becomes so difficult to teach our students, and sometimes even like in nystagmus, when there is esotropia or when there is a small DVD, we might miss these things. So if we record this and then we replay, and we have got this software nowadays, we can use this technology and update our skills.
It means that if it is some very fast motion, accuracy to make it accurately, this slow motion may be
Yes,
such as
sir.
in cricket also.
Yes, sir. Yeah, when I saw this match, just like a third referee, he plays and replays in slow motion.
Make it slow motion.
Yes,
to
yes.
see the accuracy whether it is touched.
Exactly,
or not touched.
exactly.
What is
So when I used to teach in a class, when I found my trainees over there, they couldn't understand what I was doing when I was doing this cover test and prism bar and cover test. But when I showed them the slow motion technique after downloading in video, they were like, this is it. Oh, this is it. So it was it became very apparent. So it will become very easy for them to diagnose.
I think it is a good idea to give you a little more accurate view of what you are seeing. But how does it help your patient in clinical practice?
Yes, it does help my patients, especially because I have to get all this. I have got a very fast OPD, and I have got this.
It will take more time because.
Yeah. No, it won't take time because I can now train more people around me who can get these calculations, and they can.
My point is that how does it help your patient medically?
Directly,
not from
yes.
yeah.
Directly also it does help me. Like sometimes when there is nystagmus and ESO, even I have been practicing strabismus since 15 years. Still, I make some mistakes when I'm doing this fast motions, esotropia with nystagmus or DVDs. So even I miss it sometimes. So when I did this, I found that it was very useful for me.
More so be helpful in the treatment to the patient, like if you give video to the patient. Can it
Yes,
be
sir.
helpful?
Yes, sir. Of course, it can help the patient. Yes, sir.
So probably even using a mounted kind of a thing would be better, but that is negated because you have the optical stabilization nowadays on most of the phones.
Yes, sir,
So I think.
there are new smartphones and all those things, technology.
Yeah, the OIS is there. Yeah, the optical stabilization is there. So.
We are recording these videos, but they are very costly machines and phones we have in our hands. So we can use it.
No. See, the phone does post-image processing. It does post-video processing.
Yes.
So it does the auto-correction. I think this is the best device that you should be using actually.
Yes, sir. It came out.
I think it's a very innovative idea.
Yeah, well, thank you very much. So next presenter is Dr. Vidani, Jitendra Vidani. Is this working now? No. So I'll request the judges to stick to 2 minutes as well, as the presenters are sticking to 2 minutes. Don't grill them more than 2 minutes, please.
Good idea.
Good idea. So Dr. Vidani, please.
Yes, sir.
You can speak, if video is working, you can speak over it, no issue.
Yes, they're speaking, but
If it is
too many questions. Yeah, we have to limit the questions to the candidates.
I'll play, sir?
Yes. Start the timer, please.
A very good evening. Dr. Jitendra Vidhan here from Ahmedabad, Gujarat. This is the case history. 70-year-old male patient, grade 3++ cataract, well-dilated pupil. And the rexus was made. Hydrodissection was done and it was rotated. And here I'm trying to chop the nucleus. And here I feel that it was grade 3, but as I started chopping, it felt like more of grade 4 cataract, and felt like the leathery nucleus is laughing off at me and saying to me that I wouldn't chop today. Also, I was a little apprehensive because my father was in the OR and he was watching the surgery. So I was a little excited to show that my surgical skills have improved and I can really chop the nucleus and put it into 6 parts and get it out as soon as possible. But as we can see here, it is not getting chopped at all. And multiple attempts are being made at chopping the nucleus. And here I just, the thinking was that if I could get just one piece of the nucleus out, then, my job will be easier to get out the cataract.
Why the video is stopping?
So it was working. It was working properly. I had checked yesterday, sir.
Yes, it's not your fault. It's the AV. So he's. Yeah.
Yes, sir. So as soon as one piece came out, then the job became a little easier. And after that, one by one, unlike my father would do, I just went piece by piece, and then there was one epinuclear plate adherent that was left in the end, and towards the end, I could remove it easily. And थोड़ा सा forward करिए.
Video was for 2 minutes.
Yes, sir.
Because of the problem in buffering. Yeah.
And at one point, I had come out to rotate the nucleus. And at this point, the remaining part of the nucleus, comes in the AC with the epinuclear plate adherent. And then I do not let it go inside, and then again, I emulsify it in the AC. And at one point, I feel that my chopper would hit the posterior capsule. So after the last piece is left, I just pull out my chopper so that the last piece is emulsified clearly. You'll be able to see in this. Yeah. And that's it. The case was done. Vision was 6-9 parts. Cornea was clear next day. And thank you. I would like to express my sincere thanks and gratitude to the entire scientific committee for letting me allow to present today. This was my first national level conference, so please pardon my mistakes. Thank you, sir.
Thank you. So, Dr. Hina Bhandari, are you here? Dr. Hina Bhandari.
Any innovation or any message you want to pass on to the
So what I felt through this case, I was a little apprehensive doing this case at first because, you're a young surgeon and dad has given you this case, because it's a hard cataract. And plus it was more like grade 4 cataract. So I think I should have gone a little more deep. The depth was almost 60%. I should have gone a little more deep. 80% depth I should have done, sir. That's what I would, towards the leathery end sometimes.
Sir, your comments, please. I think Dr. Jagat Raman.
The patient was a myopic patient?
Yes, sir. It was a high myopic patient, plus 15 diopter. Yeah, IOL power was plus 15 diopter.
You should have anticipated that.
Yes, sir. And sorry, sir. And the axial length was 25.04 millimeters.
Initially, you thought that it is not a hard cataract,
yes,
but
sir.
Operatively it was hard cataract.
Yes, sir.
There
yes,
were
sir.
still something in your hand, no?
Yes, sir.
Parameter you would have changed, no?
Yes, sir. But I feel that, sir, parameters was still, the machine used was Alcon Infinity. The parameters while chopping was, the vacuum was 350 and aspiration rate was, the flow rate was 22 and the power was 60. So I think it was good, but I should have sculpted more, I feel, sir. I should have gone a little more deep, sir. Thank you, sir.
Thank you so much. Dr. Param.
Usually we start and continue treatment with sodium chromoglycate, chromal, then olopatadine, bepostatin, etc. Lastly, soft steroid like cloteprenol. Usually by the age of 14, they recover spontaneously. But it did not happen such with Shoham. He continued suffering till the age of 18. I was perturbed. Once I thought, during ICC era, we used to say patients, please get your unhealthy teeth extracted prior to cataract surgery. I told Shoham, please open your mouth. To my utter astonishment, I saw unhealthy teeth and gum of Shoham. Father also expressed that he has also having unhealthy teeth and gum and showed it. So I understood that this is ocular manifestation. This is episcleritis secondary to periodontitis or gingivitis and not a vernal conjunctivitis. So I made my decision. Treatment of his gum condition and dental condition must be given priority. I advise Metrogyl D toothpaste, chlorhexidine toothpaste, betadine mouthwash and referred to one reputed dental surgeon. Yes, it was the right decision. After treatment, his gum and dental condition improved and the eye inflammation too. I have stopped all the topical medication.
Thank you. Over to the judges, please.
So basically, we're looking at periodontal disease as a cause of allergic conjunctivitis.
I think this is an important topic because documentation was also good, but maybe we may avoid showing any clip from the company or like that. Or we may have no financial interest in the product.
No financial interest, sir.
No, just to
covering
say,
2 minutes, I am to cut short.
Yeah. No, I mean to say that it is fine, nothing wrong, but we may write no financial interest in any of the thing.
Thank you, sir.
What I wanted to say was that, there were those brand names which actually got this thing. So that's why, so no financial interest probably is. So, right. Dr. Pandav, sir?
To cut short in 2 minutes, within 2 minutes, I couldn't.
No, it is a good debate which gets elicited from here, because this is something that we normally don't have in our minds when we're looking at it. We would be looking at the ocular condition, not at the periodontal.
So what was your final hypothesis? I mean, were you relating to the dental disease with the uveitis or with the allergic?
No, I like to mention that my previous idea during childhood, when people come for us for vernal conjunctivitis, we think it is exogenous, but the endogenous factors also we should always keep in mind.
No, what do you mean by endogenous? What are they causing? They are causing kind of scleritis, because you did mention the word scleritis in your presentation. So you are thinking more in terms of scleritis, or you are talking in terms of conjunctivitis?
Episcleritis.
Scleritis. So you think his problem was because scleritis, and that was being mislabeled as allergic conjunctivitis?
No, naturally it was proved later in search of unique cause.
Because there's a little bit of lack of clarity.
That
there's
is
a
not the
little
cause.
Clarity in your presentation also. Whether you are treating
I mentioned later on to alter the title, mimicking viral conjunctivitis, episcleritis, mimicking viral conjunctivitis. But I could not correct it.
Actually, you see, when we label any causality to it, there are, if you remember the Doll and Hill criteria, right now what you've shown is an association.
Yes.
And to actually impute causality, because the topic says unique cause of, so probably causality is not imputed at all. So it is just an association, and it's a valid association. Maybe further studies would elicit it further.
I wrote in the group mimicking, not the cause, but I couldn't alter the slogan. That is the problem.
Thank you, sir. So, Professor Moria, please, Professor Arvind Maria will be presenting smartphone-based annotating and screening app for accurate image labeling for common retinal disorders.
Its relay is not coming. I can't see it.
AV team, yeah.
This led us to develop
Just
our
one
own
second,
in-house image and
timer to 2 minutes, please. Not 3. Yeah, start the timer, please. Yeah.
Shall I start?
Yeah.
Relay is gone.
Please stop the timer. Reset the timer. Yeah.
Yeah.
Start,
Okay,
please.
Okay.
this led us to develop our own in-house image annotation tool. As seen in the
Volume
video.
बढ़ाइए. Again gone relay. Laptop, mine is working.
This Windows here, Microsoft.
No, is it not the AIOS laptop or?
This is your laptop, sir laptop.
So,
That's a Mac? No, this is Microsoft. Yeah, MacBook.
So ideally should have been uploaded there. For competitive sessions, yeah. No, ideally, yeah, but it could have been uploaded there.
In all sessions, I think Mac is a problem. Like, I think, no, they might.
Yes, start please.
Yeah.
Sometimes
This led us to develop our own in-house image annotation tool. As seen in the video, adding an annotation for an image is pretty easy. View the image, magnify it, change the brightness, change the contrast as needed, click on the relevant options, choose extra details, and the annotation is saved. The analytics on the landing page show the pending and completed images. The graph shows the maximum number of images tagged by other users in real time and gives a daily target setting. These imaging datasets are generally in the range of thousands and can be overwhelming for a single person. So we chunked them into sets, each containing 1000 images or less, which a grader can complete within 2 weeks. The issues mentioned earlier were resolved as follows. For faster image loading, we resize images into smaller sized thumbnails with smaller memory footprint while still maintaining the visual quality. We leverage the asynchronous capabilities of the browser and don't load just one but 3 images preemptively, so the grader does not need to wait for the next image to load. The initial interface was basic and evolved based on the grader feedback. It's now designed on a decision tree structure to render the nested subclassifications and extra options. We have seen a total behavioral change where on the online tools, the graders used to work only on the weekends, but on our tool, we have logged usage on all days of the week and in almost all hours of the day. Average time taken to label a single image reduced substantially. We validated the AI algorithms developed using annotations on this tool on some new testing datasets and found them to have really high performance scores. This strengthens our hypothesis that this tool serves no different than a desktop-based tool with the added benefits of being portable and flexible. We wish to introduce more gamification, label optimization, and even use it for telemedicine.
Thank you.
So what did you actually use? You use different ways of looking at the same image, like multiple algorithms? Yeah. Because your table shows like 3 or 4.
No, they were regarding the means the retinal specialists, they are seeing the images, right? First, this software and this application undergone validation. So 32 retinal specialists, they have seen all these images for validation.
No, there's a clinical validation, but the AI, the machine based. So you use one system or there were multiple systems?
Sorry, I couldn't get your question.
You used what algorithms or the AI platform?
Yeah, AI algorithm.
So you single platform or you had a different platforms?
It was means a website, right? And it is smartphone based. So the images were sent to the retinal specialist and they graded those images.
Yeah.
On the basis of that validation, an AI algorithm was formed that can finally diagnose, and it was the referral sort of thing, means that this image the patient needs to referral, needs to go for the higher center. This image normal, so patient just need to follow up, and regular follow-up is needed, fundus examination needed. The referral to the tertiary center is not required. So it's a referable sort of.
One of the tables you showed that show the clinical like parameters, and then in one column, then another column. So I was wondering, but I couldn't read that properly.
That was the disease schema.
Yeah.
Means all the disease schema regarding the glaucoma, diabetic retinopathy, hypertensive retinopathy. So every all the ocular common disease, they were validated.
Okay, thank you.
And for validating one disease, a minimum 5,500 images were considered as per statistician.
So actually you showed Docker with Kubernetes.
Yeah.
So Docker Kubernetes simply means it's residing on the server.
Yeah.
And this was the sir ka wahi tha कि Docker Kubernetes is what was the server side, what was the client side.
It was complete.
You're showing us the client side, and your algorithm actually is showing us the server side. Yeah. So basically, you see there are two elements to it, and sir का question दूसरे वाले element को लेके था.
Yeah, so complete anonymity was taken care, and we did the validation finally, so it was on our own server.
What I was wondering was like, what were your innovation in that? Because server is doing something on its own that you didn't innovate that. Your job was just to input the data and the clinical kind of
Annotating and grading the images, and on the basis of this AI algorithm, we were able to make a referable sort of system, means binary system, whether an image for a particular disease like a glaucoma. So there is a cupping is there, this much of cupping, this much of ocular biomarkers are there. So patient needs a referral.
Again the same thing. Again the same.
Let's move on later. We'll carry on this discussion outside. Thank you. See, basically that algorithm is running elsewhere. You are doing some annotation here. What sir is saying? Annotation. This was an annotation tool which has been developed so that the doctor can annotate it, mark it that this is a hemorrhage, this is a fibrotic band, and the algorithm runs and gets developed elsewhere.
Okay, so
capsular bag fixation method, where there is two dialysis simultaneously. So it's a novel technique. Is the video running? To fix two dialysis, iridodialysis and zonular. Literature did not help us. There's no literature. So a pocket is made, Hoffman pocket, and through this Hoffman pocket, a non-absorbable needle is passed. Then through the outer edge of the iris, and we torn iris, area of dialysis, we railroad it out through the main port, and an eye of a arm segment or a segment CTR is railroaded it and out in the reverse direction. And as we titrate the pull, the capsular bag and the iris both are approximated to their bases, and then we can have what was the gap, it is there. So a Hoffman pocket is made. Difficult rexis is done and fixed with MST hooks, capsule hook, no financial interest, CTR is placed, and now this Gore-Tex suture is being placed through the limbus, through the outer edge of the iris, torn iris, brought out by railroad, and the eyelet of a segment CTR is being threaded, and we pass it back by railroad through the same technique. Needle is docked there, and we bring it out through the bed of the Hoffman pocket. And the segment CTR is carefully negotiated into the equator against the CTR already there. And the knot is placed and buried in the Hoffman pocket. And I was confident enough to place this multiplex lens IOL in the bag. So this was two dialysis, 1 and 2. Both has been fixed at one go by a single hangback lookup suture. That is my point. a new way of doing it.
Thank you, Devashish.
And I did not.
This was very nicely done, and it has given perfect centration to the people.
It is somewhat perfect. I did I could have done a pupilloplasty along with it, but I think it would have messed the thing up.
If you do only with the suture, polypropylene or this suture,
Any non-absorbable suture will do.
even without Ahmad ring or without that, is it necessary to place that?
Sir, there is two dialysis. The zonular dialysis is there along with iridodialysis.
Yeah, I understood it.
So the Ahmed segment and CTR, Ahmed segment to be precise, takes care of the
things are
dialysis of the capsular bag, and the hangback repair through the peripheral torn iris takes care of the iridodialysis. I mean segment iridodialysis, which is about 3 clock hours, not more than that. So two at the same place, taken care by one loop of suture. So literature does not give anything like it. Thank you so much.
So this is 60 Gore-Tex?
Gore-Tex is not, this is off the label use. Gore-Tex does not follow this 60 and 10. This is the thinnest possible Gore-Tex available. This is not for ophthalmic use. This is basically for vascular surgeons,
These
but this is off the label use somewhat.
Terms of the Gore-Tex is also very much problematic if it remains exposed.
Yes, some say there's cheese wearing effect, but so far so good in our hands, not on all cases, but this was a young subject where a proline suture might have 80 or 80 proline maybe, I mean we know it has got lifespan about 10 years and beyond that it may break. So this suture is supposed to last a lifetime. So this suture is not the question of what I am stressing. It is a single loop and the application of this thing to control this two dialysis at one go. Thank you so much.
So you had a pars plana entry made.
Yes, that was to take care of the prolapse of vitreous through that area. So that is
that's already been taken care of before.
Yes. So that is not the point out here. That's what I want to focus on. Thank you so much.
Thank you very much. So next presenter is Dr. John Shortcut. Water jet to let it set.
May I proceed, sir?
Yes.
Very good evening to all of you. I'll be presenting water jet to let it sets. I have no financial interest. This is a dissect plan for the surgically traumatized eye. This is a Uber driver, surgery done somewhere else, so referred to cornea clinic. Initially I thought I will do the clubbed up with the another eyeball, but superior wound is so bad, I am sitting on the inferior temporal part, so I am planning only dissect. Everything alright up to that point, but now the real game started. So as I am just planning to inserting the graft, now the PMMA IL was propped up as there was no Irish support. So on table I decided to using the irrigation cannula in a polish mode, which will support the IOL and maintain the anterior chamber like SAM. Just like we're inserting sometime IOL. And just see how smooth they have done it without hatching. Single stroke entry. We've done it. And got a good post-op and patient so happy. I've done the other eye echo and maintained the 6/12 vision for the last 2 years follow-up. Thank you very much.
Sir,
yes, sir.
AC maintainer will also work the similar way?
Yes, sir. AC maintainer is there. Though it's a on-table decision as I didn't have the AC maintainer ready on. So on table I decided what can be replaced the AC maintainer. So we have a ready-made in our hand the AC, that is the irrigation cannula. We maintain the polish mode. So maintain the anterior chamber just like this. Some of us using the inserting the IOL only in the AC maintainer. That's like that only. So I just simply converting that technique to insert in the dissect disc. And it's totally very smooth and uneventful. It's supposed to be very much eventful. That is the too many.
So your one hand is tied with the
Yes, sir.
irrigator.
Yeah, I just holding these things just like a supporter, irrigation port, and maintain the thing in the maintain mode. That, but I have to extra adding my legs just like polish mode and inserting this as if I am just keep in mind I am just inserting the IOL. I just forget I am inserting the set disc. So it's a mental block only, sir. And that take home message.
Thank you.
Thank you very much. Thank you.
Thank you. So, Dr. Sanjay Chaudhary, please.
So, this thick plaque came up on the posterior capsule, and we were weighing our options. How should we manage it? So, I'm going to show you this sudden surprise thing before us. Bhaiya, start kar do.
Yeah.
Play.
What do we see here?
This is with sound.
A thick plaque on the posterior capsule. It is so thick that if I leave it, the patient will not have a good vision. If I try to remove it, it's most likely I'll puncture the posterior capsule. If I try doing a yak capsulotomy in such a thick plaque, even that would not work. Let me try to scrape it off the posterior capsule. Let me try this capsulotomy needle. In case I can't scrape it off, I'll puncture the posterior capsule and do a posterior capsulorhexis. And my pressure should not be too much. Slowly, patiently. Hey, it came off. It came off the posterior capsule and the posterior capsule is intact. Wow. And now I continue to tease off this plaque with a microforceps. And it is working fine. Just a little bit of strip left. Now microforceps in the left hand. I'm trying to shave it off, the posterior capsule. And yes, I'm successful. The posterior capsule is still intact. Yes, we did it.
Jagatram sir.
I think this was very nicely removed and very carefully handled because your force which you applied. If you apply sudden force, then it can rupture. So
True.
very slowly, steadily, uniformly, I think you have pulled it, and it was excellent.
Thank you, sir.
Your fantastic exposition and equally fantastic, what do I call it, the validation done by one of the greatest authorities in India. What more can I say?
Thank you so much, sir. So, next presenter, Dr. Pranita is not here. So, Dr. Sonali Prasad will be present here almost.
The Vitek
इसको दबाना इस पे इसको ठीक है अभी अभी नहीं
Yeah, please start.
Good evening, judges. The Vitek 2 device is an automated photometric system which is used for the identification and antimicrobial susceptibility testing. This instrument reads the kinetics of the growth every 15 minutes using an optical system which combines photometer and multi-channel fluorimeter readings to assess the fluorescence, turbidity, and the colorimetric signals. It is based on the minimal inhibitory concentration, which is the lowest concentration of an antibiotic that prevents visible growth of an organism. A culture of at least 24 to 48 hours old, pure culture of the microorganism is used, and it is dispensed into 3 ml of suspension solution into the disposable plastic tubes provided by the manufacturer. The emulsification of 1 or 2 colonies of the organism is done in the suspension solution using a sterile inoculation loop. The turbidity of the suspension is checked with the help of a densitometer. The optical density should be in the range 0.5 to 0.63. A repeat inoculum preparation is done if the optical density is out of range. The card with the blue strip is the identification card, and one with the grey strip is the antibiotic sensitivity testing card. For a gram-positive bacteria, a gram-positive Vitek card is used, and 145 microliter of the suspension is used to transfer into the AST tube. For a gram negative card is used, and 280 microliter of the suspension is transferred to the AST tube. The cassette is now ready to be placed in the Vitek 2 machine, and it takes around 6 to 12 hours for the whole identification and the AST. These are based on the CLSI standards, which gets updated after a change in the breakpoint, and also the same gets updated in the database. It is faster than the conventional methods that almost take 24 to 48 hours for the AST. It is also simple and saves technical time with rapid accurate results and provide a permanent documentation. It promises to have a broad applicability for bacteria, anaerobes, yeast, fungi, and with the continuous expanding database also promises to have a remote access reporting in future.
This technology which is available that you used, or you developed it?
No, sir. It is available in other microbiological lab, but this is the thing that has been using for ophthalmological use also. The antibiotic sensitivity that they give on a general platform. Many of the antibiotics are not actually available for the ophthalmic use, and the formulations are not mentioned. So it is a generalized antibiotic sensitivity pattern in against the organisms from our body.
How is that different from ophthalmic use?
Ji, sir?
How is that different from ophthalmic, or what is the different that you did, basically?
Sir, the difference is the time. So it is so rapid that it can give you the result in just 6 to 12 hours.
That's true for ophthalmic as well as non-ophthalmic. So
Yes.
what is specific about ophthalmic use of this technology?
Sir, in cases of
Which you invented?
So I haven't invented, but we are using it in our practice. Like in the cornea department, the microbiological cultures that we send, the gram coage or the blood culture, chocolate agar, we incubate it overnight, and then we take the culture and we use it for the sensitivity pattern. It gives the result in just 6 hours, and within the same day or two, we can give the
There's the technology which is available.
Yes, sir.
What is your contribution in this? Is there any? I'm just trying to assess that.
Yes.
Yeah. Is
Sir,
there any?
sir, my contribution is it's not there, but we are using it for the early assessment of a disease.
So you're demonstrating.
Yes.
Demonstrating technology.
Yes, sir.
How that
Yes,
can
sir. And
be-
how we are using
can
it
be
for
better used
earlier
for
demonstration.
ophthalmology.
Compared to the Kribibor method, the disk diffusion method, it takes around 2 to 4 days. So we are diagnosing
Yeah,
it
we get your
within
point.
6
Thank
days.
you.
Okay, and is the the AST that it does it have the sensitivity to say moxifloxacin? Because
Yes, sir.
the other ones don't have it.
They give the sensitivity pattern against the moxie, but they cannot say whether the topical or the ointment form, but they give the sensitivity pattern against moxie, sir.
Okay, so basically ophthalmic specific
it is not.
antibiotics, this is going to give you the results against ophthalmology specific antibiotics also.
Yes, sir. Yes, sir.
So you have added those antibiotics yourself, or they come?
No, sir. They come with the system itself, and there are around 14-15 antibiotics. And when they develop another new antibiotics also, they are also included in the system, in the database, sir. It is yearly updated, sir.
Thank you.
Okay. Thank you, sir.
So with that, we come to the close of this session. The announcement will be made later on, or what happens?
Yes.
Yeah.
You can do it now if you want. कर देंगे सर 5 मिनट.
Okay.
Moderator लग जाएगा कर देंगे. हाँ सर.
In other session,
Okay. So we can hand it over to the hall. No, that's how it happens. We hand over normally to the hall coordinator, they hand over to the scientific committee. Oh yeah, that the mobile has to use. Oh, you are doing it.
We are not announcing it.
You have done it. Shinning and grilling and marking. Thank you so much.
All the speakers, please come. सर लाइट के थोड़ा पीछे ना खड़े Look, sir, look here.